Naomi Poole, as Program Manager, is the Director of the Partnering and Consumer Program at the Australian Commission on Safety and Quality in Healthcare, where she's involved in leading and coordinating national policy on partnerships with consumers, health literacy, end-of-life care and shared decision-making. She has a degree in psychology and worked extensively at a national level in population health policy, program development for Aboriginals and Torres Strait Islander health and national health screening programs and child and youth health. So I get you to welcome Naomi.
Hi. Okay, so I'm here today to talk to you about the Commission and the standards and the changes that are coming up with the standards. So I'm going to do a little bit of a kind of 101 for you about the Commission itself, where we've come from and how we've kind of ended up where we are today. So with the Commission, so around about 10 or 15 years ago, there were a series of tragic events and failures to address poor clinical care in a number of hospitals across Australia, which resulted in some significant harm to patients. So I'm sure you've heard of many of them before. So there was issues in Camden and Campbelltown Hospital around senior staff failing to act on and address safety and quality concerns. There were issues in Canberra Hospital around some neurosurgical safety. And also there's some issues in King Edward Memorial Hospital in Western Australia, where there seemed to be some high rates of stillbirth compared to other hospitals. And also around about the same time, a little bit after, there was also the case of Dr. Patel in Bundaberg, which I'm sure you're all aware of. So what happened is there was a review of all of these events to try and identify if there were some underlying causes and why the kind of poor care and the outcomes, the poor outcomes, were continuing on a long period of time. And what they found was that there were patterns of systematic failures associated with inadequate governance. There were inadequate systems and processes for safety and quality. There were issues around clinical leadership and culture. So there were systems, and there were no systems in place that are available for people so that they felt like they could speak up about issues that were ongoing. And so what happened then is that the Australian Council on Safety and Quality in Healthcare was established, and they were established to look at safety and quality nationally and to try and bring some kind of coordination and collaboration and some national leadership around safety and quality issues. And the Commission initially focused on some of the key safety and quality issues, the classic ones like medication safety and healthcare-associated infection and communication. But we also looked at the systems and structures and concepts that are needed to support safety and quality, such as accreditation, education, leadership and governance, as well as patient-centred care and patient-centred systems. So at the moment, the Commission has a focus on a number of different activities. So we look at things like, we look at national data and publish reports like the Australian Atlas on Healthcare Variation, which gives an indication of the kind of variability in practice across the nation. We also do national policy on issues like end-of-life care and medication safety, as mentioned before. And we also develop two different types of standards. So we develop the National Safety and Quality Health Service Standards, which are the ones I'm going to talk about today. But we also develop another set of standards, which are clinical care standards, which focus on particular clinical issues and identify where there's best practice available there. Okay, so we're actually funded both in a cost share arrangement. So we're funded by the federal government and we're also funded by state and territory governments, which means that we actually work with all of the health ministers and all of the health departments to try and come up with the types of policies and processes that I'm talking about today. So what I'm going to talk about today, so I'm going to give you a little bit of patient-centred care and partnerships with consumers 101, because I understand there is a bit of variability in kind of knowledge, and we use terminology in a different way than some of the different departments and health services and everybody. So I'll just explain kind of what we mean when we talk about partnering with consumers. And then I'm going to talk about the standards as a disruptor. So there are the current standards that are in place, but as already mentioned, we're in the process of developing the second version of the Safety and Quality Health Service Standards. So I'll talk a little bit about where we're going to go with that too. And I'm also going to get you just to have a little chat at your tables as well about what the implications of the current version might be for you and also what the changes might mean. Okay, so when we talk about partnering with consumers, I'm sure you've noticed, and it's been mentioned a couple of times this morning, that there's a whole lot of different terms that are bandied around, and there are different, it depends what profession you are, what kind of background you've come from, where you've where your theoretical preference might be, your clinical specialty, the sector that you work in, about what you use, whether or not you use patient, people, consumers, clients. They're all used fairly interchangeably. And there's also quite a lot of kind of discussion about whether or not it's patient-centred care or patient and family-centred care or consumer-centred care or person-centred care. And to be honest, the Commission has basically gone along the whole gamut. So we started at patient-centred care and then we started talking about consumer-centred care. We talk about partnerships at the moment, and that where we are heading as well is for person-centred systems and person-centred healthcare processes. So that's kind of, I think, is a bit of an evolution, but quite often they're used interchangeably, and I may actually accidentally use those interchangeably today, but don't worry about it. We're all talking about the same kind of thing. So, and also, when you've got all these terms, you've also got a plethora of models available. So basically, everybody who has done a piece of research in this area has tried to conceptualise all these different ideas into one thing, and it actually makes it quite complex. So you often end up with this trying to pack all these different ideas into one thing. But what is it really? So when we talk about patient-centred care, what we look at... Oops, too far. Okay. We talk about, in its simplest form, we're talking about healthcare that's respectful and responsive to the preferences, needs and values of the patient and consumers. So there are some widely accepted dimensions of patient-centred care, and they're things that have been talked about today. So we're talking about respect, we're talking about emotional support, physical comfort, information and communication, continuity and transition, which has come up a few times already, care coordination, involvement of families and carers, and access. And these are the types of domains that are usually used when people are measuring patient-centred care. So when I talk about some of the evidence later on, that's quite often how they determine whether or not care has been patient-centred, if those domains are covered off. But conceptually, how we see patient-centred care is we see it as a holistic approach based on the internationally accepted biopsychosocial model. So this is about health and well-being. It's not just looking at the person's condition at a particular point in time or their particular issue. It's looking at the person as a whole in their entire context. We also see patient-centred care and partnerships as about the empowerment of the person based on human rights. So emphasising equality, needs-based care, and the involvement in people in their healthcare and their decisions about their healthcare. And we also see it as being integrated and universal access. So beyond just coordination and collaboration at a vertical level, to inclusion and participation and community care, and engaging the person and assessing their personal factors such as quality of life. So that's basically why it's difficult to explain simply and succinctly, and why it's difficult to have a simple one-sentence definition and a simple diagram of what it is, because it's very complex and it can be very different. It can look different in different circumstances. And one of the most important things to note is that it's actually context specific. So there's no single model of patient-centred care, because each context for each person and each health service will differ. But there is a common framework that we're looking at. And what we talk about is patients. We talk a lot about partnerships with consumers, and we see partnerships as a mechanism for how you actually achieve patient-centred care. So engaging in partnerships demonstrates your commitment to treating patients with dignity and respect. It supports communication, it facilitates collaboration, co-creation, shared decision-making, all those things if you have a real partnership. One of the other things that I just wanted to make clear for you as well is the way that we see the different types of partnerships with consumers. So we see primarily two types of partnerships. We see the partnership between the patient and the healthcare provider who's providing the clinical treatment. So this patient-centred care in this context looks like good communication, shared decision-making, providing information about the treatment and options, and making sure that that information is easily understood. It's about involvement of families and carers and other support people that the patient wants involved in their care. And it's about eliciting, identifying and showing respect for the values and preferences of the patient on a one-on-one basis. So this is about partnering with consumers to improve their own care. The other type of partnership is about partnering with consumers, so it can be a patient, it can be a carer, it can be a family member, it could be someone from the community more broadly, with the health service in order to improve the care for a broad range of people, so for the people who use that health service. This type of partnership focuses on gaining an understanding of the experience of people receiving the care in that health service and assessing that experience and identifying what are the things that have gone well and what are the things that haven't gone well in order to identify where there may be opportunities for improvement. It's involving consumers in the strategic and project planning, so identifying what consumers want, what makes care easier, and what makes things like information easier to understand. So it's about planning and design and quality improvement and involving consumers in those kind of structural and governance arrangements. One of the things to note as well, that when we talk about involving consumers in the governance of an organisation, we strongly encourage people to involve multiple consumers and to identify the appropriate consumers. So a consumer who has an interest in a particular area and who has kind of relevant skills in that area. So my classic example is not establishing a committee and identifying a 75-year-old consumer to be involved in a project around service redesign for a children's hospital. So making sure that you're matching the needs of the engagement with the needs and the skills and experience of the consumer. And at the same time, you also need to make sure that you support that consumer who's involved in that engagement and that partnership, so that they can actually contribute and engage and speak up and be involved and be confident in their partnership and their role that they play. There also need to be clear as well that there are a range of different types of partnerships. So you can have short and long ones. You can have, as mentioned before, you can involve consumers in partnerships in committees, in information development, in projects. And there's no one way that you can do it. It depends on the project that you're trying to do. So they're the two types of partnerships that we talk about. Just to give you a little bit of background about why we came to the point where we started talking quite strongly about partnering with consumers in patient-centred care. A couple of years ago now, we did a background paper on patient-centred care. So we were just having a look at the landscape, having a look at what was happening internationally, what was happening in Australia, where the levers for change might be in this, and where the evidence is for patient-centred care and partnerships. This was done in around, I think, 2011, and there's quite a bit of new research that's come out since that time, particularly around things like the patient-centred medical home model that's been trialled in the US and some of the stuff that Tracy has talked about earlier this morning. Okay, but there's, even from 2011, there's some pretty clear evidence that engaging in partnerships with consumers and patient-centred care can actually have some quite significant benefits, not only for the consumer and for the health service, but also for clinicians and the health system more generally. Having a look at some of those in a bit more detail, one of the studies that we look at or have seen or talk about quite often is there was a study about acute myocardial infarction and patient-centred care, and this study found that there was a significant but moderately lower risk of death just from implementing patient-centred practice, and particularly the kind of domains that were of particular impact were coordination of care, attention to patient experience and physical comfort. Another more recent study looked at patient activation and how that impacted on health outcomes and costs over time. And they basically found that the results showed that higher activation, unsurprisingly, was associated with better health outcomes, including clinical indicators, more healthy behaviours and greater use of preventive health screenings, as well as lower costs up to 2 years later. There's also been some research that's shown that patient participation was associated with favourable judgments about hospital quality and reduced the risk of experiencing an adverse event, which is highly important for safety and quality. And there's also been some interesting research around staff experience and patient experience as well, and the association between the two. So many of the US organisations have a strong push on staff experience, improving staff experience and patient experience together. Studies of the health services that adopt these kinds of models and focus on patient-centred care have been shown to have better staff experience, greater retention, and are often considered magnet hospitals, particularly for nursing and allied health staff. This particular study found that positive feedback on the availability of hand washing was associated with better patient experience, and negative staff experience reflected poorer patient experience. There is a kind of debate. It's a bit hard to tell if there's a chicken or an egg thing. Is it that happier staff take the time to engage with patients and that their families and thereby deliver more patient-centred care? Or is it that taking the time to deliver patient-centred care gives staff greater satisfaction and engagement? I think it's a bit unclear, but what is clear is that they go hand in hand. So if you work on staff experience as well as patient experience, then you'll improve. There's also reasonable quality evidence around involving consumers in the co-design of services and information, and some of that's been touched on this morning. I mean, it makes sense that if you were designing information or a service or a process for consumers, that you would involve consumers in that design in order to improve the likelihood of it being kind of useful and acceptable and accessible. There have been some Australian studies around this, particularly around some work that was done in New South Wales around emergency departments a few years ago, which showed that there were significant improvements in patient experience using these co-design processes. So a lot of these studies show that when healthcare administrators, providers and families all work together in partnership, then the safety and quality of healthcare improves, costs decrease and patient and provider satisfaction improves. So there is a concept. There's a good concept, there's evidence, it's a good idea, it's good for outcomes for hospitals and staff, and it's obviously the right thing to do. But how do you actually influence action and get this quite nebulous concept into practice in hospitals? So there are, in terms of background as well, there are a number of international policy frameworks that have been around for quite some time. So the Alma Ata Declaration was probably the first one, and the one we talk about as being the kind of the first one that starts conceptualising patient-centred care and a population health approach to person-centred care. It has been around for almost as long as I've been alive. And obviously it's not completely infiltrated into the entire population health sector. So obviously there's some trigger that needs to happen in order to make that change occur. There's also been a lot of work done in the Institute of Medicine in the UK around person-centred care, patient-centred care, engaging with consumers. It was identified in the Institute of Medicine's report, which is probably quite some time ago now, in the early 2000s, as one of the 6 quality improvement aims for healthcare. And in recent years, these policy frameworks have been supported by a number of policy and program levers within these governments. So in the UK and the US, they've tried to implement things like mandatory government requirements for service providers to collect and publish patient experience data. They've also made publicly available information that enables consumers to choose between different healthcare providers. And they've also put in place things like financial incentives for providers who achieve higher measures of patient-centredness. I think the jury is probably still out about the effectiveness of some of those levers, and some of the kind of processes are still changing. But there is quite a bit of experimentation in that area. And there are also internationally, there's been a lot of kind of policy frameworks and guides that have been developed in the US and the UK in particular. In the US, there's a number of organisations like Planetree and the Institute for Patient and Family Centred Care who've been developing toolkits and guides for quite some years, which focus on things like staff development and leadership, about how different methods of collecting and reporting on patient feedback, and about redesign and co-design, and things that focus on the implementation and development of patient charters of rights. So there's quite a lot of work in the field internationally, and it has been going on for quite some time, but it has been a very incremental pace. In Australia, we've also got quite a few policies that talk about partnerships and patient-centred care. There's a lot of our policies that identify as a kind of vision or a goal or an aim that the healthcare system be patient-centred in terms of the primary care strategies that have been around for quite some time, and the mental health strategies that have come out. And it's increasingly being used as a founding principle for the restructure of funding models. So just in the last kind of couple of years, such as through the NDIS and the new approach to commissioning mental health services, and the project that Tracy talked about this morning, where there's piloting the patient-centred medical homes. So there is some movement around how you might change funding structures so that they do actually support the principles and the visions that have been elicited in these frameworks for quite some time. The Commission has included partnerships and patient-centred care as a core requirement for pretty much all of our safety and quality policies since we've started. So they're in the framework, they're in the goals for safe and high-quality care, they're in the Charter of Healthcare Rights. We seem to talk about it a lot, but again, the action is a little slow. So where it has sped up for us over the last couple of years is obviously around the National Safety and Quality Health Service Standards. And the reason for that is that the Commission's not a regulatory body, so we work by gaining agreement and consensus, and we work with governments, state governments, federal governments, colleges, universities, health services, to try and gain consensus about a national way that things should be done. And we work by collaboration largely. But the Safety and Quality Health Service Standards are actually a much stronger lever than that, because they are actually mandatory for a large proportion of health services, so hospitals and day surgeries. And so consequently, it does have the most influence in terms of our work. So the standards themselves, for those of you who aren't familiar, so right back when we started in 2006, this was one of the first things that we were tasked with. So we were asked to have a look at the accreditation system in Australia, have a look at the strengths and weaknesses of the then current model, to have a look internationally and see what might be able to be used as a model for here in Australia, and then to develop a process and a timetable for reforming the accreditation process and for developing a set of safety and quality standards. And part of the reason for doing this came out of those tragic events that happened 10 to 15 years ago, because a number of those services that did have those events happening in their area had actually been accredited, or quite often, some of them had actually been quite recently accredited when those things came to light. So there were concerns about the safety and quality of the accreditation processes in Australia at the time, because they were seen as kind of fragmented. They were complex and quite resource intensive. They were seen as not necessarily being entirely transparent for governments and consumers. And there was also a concern because there wasn't one set of standards that were applied across all healthcare settings. So it took around 5 years to develop the first set of standards, largely because there was a lot of consultation involved in that. We initially identified what the key safety and quality issues were for this sector, and we established a range of different advisory groups to help guide what the actions within each of the standards and the models and the intent would be. We had many consultations, both targeted and public, around the standards to try and make sure that what we were doing wasn't going to be a complete shock to the system. They were piloted in a number of places. We also, as part of the process, we have to do a regulatory impact assessment to try and identify what the level of burden on the system would be for that kind of change. We also go through a whole series of processes around ensuring that that we provide training and support to the accreditation agencies to make sure that they understand what our intent was, and that when they're actually out there interpreting the standards, that the same intent is going across the field. So we developed this over 5 years. It took quite a long time and a lot of consultation across Australia. In the end, the final process is to get it endorsed by all jurisdictions and by health ministers. And then in January 2013 it started. So this was quite a big task, and the first time that the Commission had worked in this area. So it was quite a lot of kind of toing and froing and tweaking with the standards. And just to give you a bit of context as well, the Commission's role is to set the standards. So we identify what the intent is, what the criteria are, what the actions are, and what the overall approach is for the standards. The accrediting agencies are the ones who actually do the surveying, so they assess against the standards. And then the regulators, which are generally the state and territory health departments, are the ones who act if there is a particular issue identified. So it's kind of like this tripartite kind of group. So we have control over the actions within the standards, and that's kind of our remit, and so we provide advice and guidance on what our intention is for those standards and for the actions, but we don't actually assess them. Okay, so now we come to Standard 2, so partnering with standards, so partnering with consumers. When this was introduced in 2013, it was quite new and quite daunting for some organisations. So in the former model, organisations didn't have to be accredited against this type of thing before, so it was quite an adjustment for people to make. But the rationale and the evidence is there. So it is a safety and quality issue. We considered it a significant safety and quality issue. In fact, we considered it so significant that we did make it one of the two overarching standards. So both governance and partnering with consumers were the two ones that needed to be considered in the implementation of all of the other standards. So this Standard 2 in this first version has quite a discrete focus though. So when I was talking about partnering with consumers before, this standard basically covers partnering with consumers in the governance of the organisation. So this is engaging with consumers in order to improve the service for all. So using experience and partnering in for safety and quality improvement and those kind of things. So it's about engaging with consumers in decision making about the health service, so in planning and design and evaluation and review of the services. And it can be about involving consumers in co-design, whether it be physical spaces, systems, information, or training, co-design through training. So it doesn't actually focus on partnerships to improve patients' own care. Okay, so I'm sure those of you who've been through accreditation are quite familiar with this, but this is the way that we like to explain the standard to people, is that it's kind of, the actions are grouped into 3 different areas. So there are actions around partnerships for improvement, so that's about the kind of quality improvement, the evaluation, so co-design. There's also partnerships for improvement, partnerships with consumers around information and improving information. And there's partnerships with consumers about training. And all of those fall out over an overarching governance and policy framework, which describes how you engage with consumers in the governance of the organisation. So throughout the standards, we talk about executives, managers and leaders taking action to embed partnerships with consumers in the organisation systems and structures. So the intent is to make partnerships with consumers part of business by being part of that governance structure. So when you're looking at the standard and you see these groupings, we like to try and get people to think about how they might be able to implement activities or actions or projects that might meet a number of those actions within the one activity. So you may be able to do something that will cover off quite a number of those without having to actually individually address each of those standards. Actions, sorry. Because I've been talking for a very long time, what I thought I might do is, if everybody has at least a couple of people at each of your tables, or if you're on a table by yourself, if you want to come in a little bit closer where there's someone else, just wanted you to have a quick chat with the other people on your table, just to talk about, are you involved in accreditation where you currently stand in your role? And if you are, what do you see as the challenges that you face? What are the opportunities in having that kind of structure and having that standard available? And who would you need to engage in order to meet those requirements of the standard? So some of you will be consumers, and some of you may not have been involved in accreditation processes, and some of you will be right in the midst of an accreditation process right now. But just if you could have a little chat with the people at your table and think about what these kinds of actions might mean for you within your organisation, or how you could get involved if you were a consumer in order to work with your health service that you use regularly to meet those requirements. So if I can get you to come in. Do you want the next one? And I am going to ask at the end what everyone thinks are the challenges and opportunities. So I will ask for volunteers to answer, but if you don't volunteer, I will pick on tables.